Parkinson's disease is a neurodegenerative disease that mainly affects the substantia nigra. The substantia nigra contains dopaminergic neurons which secrete dopamine that is essential for fine motor function. Parkinson's causes the loss of these dopamine-producing cells. Parkinson's disease is identified through physical symptoms such as bradykinesia, rigidity, and muscle tremor. Levodopa has been the gold standard for treating Parkinson's disease since the 1970s. Compared with other available dopaminergic therapies, levodopa is associated with the greatest improvement in motor function. These claims are based on the reduced scores in the Unified Parkinson's Disease Rating Scale. Although it is effective in alleviating physical symptoms, it is not a cure. Levodopa is used to slow the progression of disability caused by Parkinson's. It is one of the best tolerated drugs to treat the disease, particularly in the elderly population where it is most prevalent. However, levodopa can cause complications over prolonged use. Drug-induced dyskinesia is a common problem and occurs in about 1/3 of patients within 2 years of exposure. Therefore, it is important to not rely on levodopa as the sole treatment of Parkinson's disease. Other treatment options such as dopamine agonists have reduced risks of causing motor complications, but are not as effective at treating the physical symptoms and come with their own side effects. A combined treatment of dopamine agonists and levodopa is the most effective way of treating the symptoms of Parkinson's while reducing the possible side effects that come with long-term exposure. This will greatly improve quality of life, slow down the onset of disability, and reduce mortality rates associated with the progression of Parkinson's disease.
In Parkinson's disease, you have a degeneration of dopaminergic neurons. This means that we have no or low levels of dopamine produced by cells in this area. Now, these neurons in the substantia nigra are protected by the blood-brain barrier. Essentially, the treatment of Parkinson's disease is to provide more dopamine. Levodopa is a first-line drug and precursor to dopamine and is given because it is able to pass the blood-brain barrier into the neuron, whereas dopamine by itself cannot. Unfortunately, in the peripheral system, levodopa is broken down into dopamine by L-aromatic amino acid decarboxylase, so only about less than 5% actually reaches the brain. Levodopa is only useful if it passes through the brain. So usually a combination of levodopa and decarboxylase inhibitors like carbidopa are used. They prevent the peripheral breakdown of levodopa to dopamine, allowing up to 10% of levodopa to move past the blood-brain barrier. In the neurons, levodopa can be converted to dopamine by dopamine carboxylase. Thus, this neuron is able to release more dopamine, lessening the overall symptoms of Parkinson's disease.
As mentioned before, idiopathic Parkinson's is usually characterized by the degradation of the substantia nigral neurons, but there is no easy way to look at the conditions of the neurons in diagnosis, and often diagnosis is made by observing the external symptoms of the disease, not the physiological change. So, some people exhibiting Parkinsonian symptoms may be wrongly diagnosed and put on levodopa. The question is levodopa safe for these people? Specifically, does it damage the precious substantia nigra while covering up its tracks with a temporary improvement in motor function? Well, an observational study conducted from 1968 to 2014 says all good. In this study, 26 key patients were treated for Parkinson's with levodopa, although they had no substantia nigra degeneration. They were used in this study. Notice that although they were treated some over 10 years with levodopa, they showed no substantial nigral degeneration or pigment change. Something to consider is that the patient evaluation methods may have changed during these 46 years of this trial, notably from the Webster scale to the Unified Parkinson Disease Rating Scale, or UPDRS. The clinical trial, a retrospective observational study, was conducted well. Although it was not a randomized, placebo-controlled, double-blind trial, observational studies like these are effective in determining the association between levodopa use and the substantia nigral non-toxicity. The study used qualified neuropathologists who undertook the autopsies, and only patient clinical records were sent to be reviewed by the 4 authors of this paper. Is levodopa effective? Well, 2 studies comparing ropinirole and pramipexole to levodopa indicates effectiveness is mixed. Patients treated with ropinirole, a dopamine agonist, exhibited dyskinesia earlier and more frequently than those with levodopa. Also, irrespective of levodopa supplementation, 20% of ropinirole subjects experienced dyskinesia by the end of the 5-year course, whereas levodopa only had 45% experiencing dyskinesia. Thank you for listening.